Thank you so much for joining us both in person and virtual. This is our presentation of a roundtable out of crisis, still in COVID, and what to do next. We have a wonderful panel of experts, both to LDH and external to LDH, and we appreciate their time with us today. As many of us know, we have spent the probably last 2.5 to 3 years, right, in the midst of COVID. And for a long time, Bureau of Community Partnerships and Health Equity, we ran a lot of webinars to educate the community on COVID, especially its health disparities effects. We transitioned last year to do more candid conversations and felt like it was time for us to readdress COVID in a professional and intimate manner to help people understand where we are, what is things like long COVID, how do we live with residual effects of COVID, and how do we move on from the pandemic stage into what we now know as just a communicable disease of some sort. And that we're going to get the experts to tell us whether that statement is right, wrong, whether there's another way for us to define it, and for how we should live with this for the rest of our days. So I think it'll be a wonderful presentation. We'll have a couple of presentations and then a panel discussion. Please make sure that you are in the chat. You can ask any questions. I believe there's a Q&A function if you're online. If you have questions here in the room, I think we may have some cards we can pass around to ensure that we get your questions and get them to the panel as needed. A few housekeeping tips. If you are in this room and you are looking for the Medicaid meeting, there's another room, 173, that is down the hall. That's for that meeting. If you're here for the COVID roundtable, that is this room. Secondly, the restrooms are down the hall to your left when you leave out of the door, and then around the corner to your left. If you have any questions, any of the staff in the back will be able to assist you and walk you to the restroom. Additionally, if you parked in the Galvez parking garage, we do have blue cards for you to get out and to validate that. So please let us know if you need that blue card. Any questions? My Bureau of Community Partnerships and Health Equity team is in the back, and they will be able to assist you. I guess I didn't even introduce myself. I'm Devondra Brown, the director of the Bureau of Community Partnerships and Health Equity. This is so not about me. It is about these wonderful folks that are at the table. And so I kind of forget to make sure that people are aware, and I introduce myself. So with that, we will go ahead and start. I want to introduce our moderator for today, Dr. Joseph Cantor. Dr. Cantor serves as the state health officer. That's the top medical official of Louisiana Department of Health. He consults on issues relating to policy, programmatic implementation, quality, and accessibility of care, health equity, emergency preparedness, and infection control, and bearing responsibility for enforcing the state's sanitary code. His previous state roles have included Assistant State Health Officer, Interim Assistant Secretary, and Regional Medical Director. Prior to joining the Louisiana Department of Health, Dr. Cantor served as the Director of Health for the City of New Orleans and led Mayor Mitch Landrieu's comprehensive opioid mitigation strategy, which included issuing a first in the state standing order of naloxone, equipping the New Orleans Police Department with the reversal medication, increasing availability of medication-assisted treatment, promoting harm reduction services, and initiating a citywide effort to reduce the stigma of addictive disorders. A practicing and board-certified emergency physician, prior to medical director of the healthcare for the Homeless Clinic and clinical assistant professor of medicine at both LSU Health Sciences Center and Tulane School of Medicine. Dr. Cantor cares for a diverse spectrum of patients in the New Orleans area, including some of the most vulnerable in our community. He is a committed academic and works closely with residents, students, and other learners. His primary interests are expanding access to patient-centered care, promoting health equity, and creating efficiencies in systems of health while protecting vulnerable populations. I give you Dr. Cantor. Thank you, sir.
Devondra, thank you so much for that warm welcome, and to the Bureau of Community Partnerships and Health Equity for all the work that you guys have done throughout the pandemic and beyond. Warm welcome to everyone who is here, both in person and online. It's really nice to see everyone. You know, COVID is clearly not the 5-alarm fire that it was 1 or 2 years ago, but it's also has with us still and hasn't left us and will be with us for some time. And that's certainly true for long COVID and associated symptoms, which as a medical diagnosis and also as a public health problem is something that, to be honest with you, we're just beginning to grasp and beginning to understand. And there's a lot more out there to learn than we know right now. So that's really what we're going to focus on as we get into today's session. So we're going to start with a overview of the data and epidemiological trends to bring us up to date with where we are now, and then we'll move in to the moderated session of this panel. So first, I'm going to introduce Dr. Lee Mendoza and Teresa Sokol, who are going to walk us through where we are currently with the data surrounding the pandemic. Dr. Mendoza is a healthcare research and technology professional with more than 30 years of experience. He did his studies at LSU, Florida State, UL Lafayette, as well as UNC and University of South Alabama. He's currently the director of the Bureau of Health Informatics in the Office of Public Health at LDH, and where he and his team produce a wide range of analytics, data products and tools, including the Louisiana Opioid Data and Surveillance System and our COVID-19 public-facing dashboard, which is one of the first dashboards in the country and still a leading dashboard out there. His team really does tremendous work. And sitting directly next to me is Ms. Teresa Sokol, who has worked in the Louisiana Office of Public Health for more than 20 years. She is our state epidemiologist. She's the program director for the Infectious Disease and Epidemiology section of the Office of Public Health. She oversees infectious disease surveillance for more than 80 infectious diseases and has led our epidemiologic response to outbreaks such as hepatitis A, Zika, mumps, COVID-19, monkeypox, and many, many others. Both of these two individuals have worked tirelessly throughout the pandemic, and I can't tell you how grateful I am on behalf of the state for their services. So without further ado, let me turn it over to Dr. Mendoza.
As Dr. Cantor said, I'm Lee Mendoza. I'm the director of the Bureau of Health Informatics. So the many things that my fantastic team does, we are responsible for the data processing and the presentation of the COVID-19 data in the state's COVID-19 dashboard. So let me tell you a little bit about the data before, the caveats of the data, and the problems with the data and how we address those problems before we get into the actual data itself. So for COVID-19, one of our primary data sources is the COVID test. So when you aren't feeling well, you go to the doctor swabs you, doctor sends the swab off to the lab runs the test, does the processing, and then sends the results back to the physician or the provider. It also sends the information back to LDH. It's one of the reportable diseases. And what we discovered early on when we were looking at these tests was that some of them were duplicated, some of them were missing information, some of them had incorrect information, but one of the primary flaws with the data that we saw was that it was missing race information. Race information was missing on about 50% of the tests that we received. Now, we weren't the only state that saw this. Every other state in the nation saw this as well, missing race information on these tests. So now currently, I guess at the national level, data completeness is at about 66%. Right? So there's a big chunk of information that's missing at the national level. In Louisiana, we've done certain things to improve that completion rate to better than 95%. So how did we do it? Well, one is provider outreach. We work with providers very closely to help them understand the importance of us receiving that information. Otherwise, we can't analyze information to tell us, are any groups being disproportionately affected by COVID? We need to understand these things. If there's a problem, we need to have it in front of us. Otherwise, we can't address it. But one of the other things that we did was, because it was a public emergency, because the governor had his emergency declaration and mandated that state agencies work together, we were able to match our information against the information from other agencies. Now, not only did we have that governor-driven mandate, but we also put certain legal things in place to protect privacy, to make sure that the data were only going to be used for this purpose, in that as few people as possible were able to see the information. So we matched against data sources like Office of Motor Vehicles and Medicaid and some of our other healthcare providers to pull in that information. And that's how we got to better than 95% complete for race information on the tests that we have. Now, once we have that information on tests, we can use that for determination of race on cases. And we can match that against the vaccine information as well to make sure that that information is as complete as possible. So that's how Louisiana has, a much better completion rate than other states. Improving our data quality lets us do these kinds of analysis. So what this shows is, if you can see across the top, the black line is the surges in Louisiana. This is the case count over time, right? And each of the colored blocks represents one of the surges in Louisiana. Now, we did this analysis. Do I need to move this? A couple of months ago, so it doesn't have the most recent information. It only goes out to about this beginning of December of 2022, but you can see at that time, we had 6 distinct surges. Is this something I need to wrestle with? All right. We'll reboot later. All right, so now that we have race information, we can look at each of these surges and look at the proportion of cases by race in Louisiana. And these maps show the geographic distribution of cases over time. So for this first surge, the orange block, you can see down here at the bottom, we have the distribution of cases according to race in Louisiana. And in that first surge, we saw that 56% of the cases were among Black Louisianans. And only about 25% of the cases were among white Louisianans. So if you know anything about the demographics of Louisiana, you know that that doesn't match, right? We know that 33% of the population in Louisiana is comprised of Black Louisianans, and then 64% comprised of white Louisianans. So this does not match at all. But you can see in subsequent surges, as the geographic distribution of COVID dispersed throughout the state, that the proportion of cases more closely resembled the demographic makeup of Louisiana. Another data source that we use to help drive our actions is the Social Vulnerability Index. So we really started using the Social Vulnerability Index during COVID. The Social Vulnerability Index, for those of you who don't know, is a way of describing communities in terms of their vulnerability to natural disasters and other events. It's a way we can identify underserved areas of the state. So this is a rank order of geographies, either by parish or by census tract. And the index is made up of 4 main factors: socioeconomic status, household characteristics, racial and ethnic minority status, housing type, and transportation. But each of those categories has subvariables that are important for the work that we do. And what I'm showing is the latest version of the SVI. This is the 2020 version. We haven't completely adopted it yet, but we're using it in some of our work. And there are some changes here. For example, housing cost burden is a new factor that's being included in the Social Vulnerability Index. And this is the percentage of people in a geography that spend at least 30% of their income on housing, right? So they have less disposable income. But it still has some of the classic variables like no vehicle. That's important. We need to know in some geography if people don't have available transportation. That helps drive some of our outreach efforts. And this is an example of how we use the Social Vulnerability Index to drive our actions. When we were looking at vaccine site selection, it wasn't always where you can just run out to CVS and get a COVID vaccination, right? In the early days, supplies were limited. We had to be very methodical and thoughtful about where we distributed vaccine. We wanted to make sure that we did this in an equitable way. So very early on, in December of 2020, when vaccines were first becoming available, Dr. Phillips said, let's identify underserved areas of the state so we can help determine where we're going to distribute vaccine. And so Dr. Cantor, Dr. Phillips used this tool to help determine where in the state do we need to distribute vaccine. These darker areas are areas that are more vulnerable. Lighter areas are areas that are less vulnerable. The dots indicate a potential vaccine location, either a clinic or a doctor's office or a pharmacy or someplace where there was a professional who could administer a vaccine. So using this tool, we could ensure that the vaccines were distributed where they needed to be for everyone in Louisiana. And then finally, I know we only have a few minutes, and Teresa Sokol is going to get much more into the data and be able to provide much more recent information. But I did want to talk about this for a quick second. This is our current bivalent equity. So bivalent shots have only been available since October of last year, so it hasn't been very long. But what we're able to do now that we've improved our race information, and now that we're focusing our efforts based on the social vulnerability index to outreach to all populations, we can see that of our bivalent shots, and we've only had 316,000. This data is current as of yesterday, 316,000. All right. By contrast, the total number of vaccination shots in Louisiana is at about 6.8 million. So this is just a drop in the bucket, these bivalent shots. You can see the counts by demographic breakdown and how the doses are broken out by percentage compared to the population in Louisiana. So for example, you see that 33% of the population are Black Louisianans. They received 33.1% of the bivalent shots. For white Louisianans, 60.9% of the doses went to white Louisianans, who make up 62.4% of the population. So, I consider this a real success. We don't see some lopsided distribution of vaccine for the bivalent boosters, but rather it's more reflective of the demographic population of Louisiana. So this is just a very small slice of total vaccinations over a very short period of time. So I think Teresa Sokol is going to have data that shows other aspects of our vaccination efforts. And with that, I'm going to turn it over to Teresa Sokol, our state epidemiologist.
Hi, everybody. I'm Teresa Sokol. I'm the state epi for the Louisiana Department of Health, and I'm hoping to be able to provide an overview of Louisiana's experience with COVID that I'm hoping can provide some context for this roundtable discussion. So a lot of you are probably familiar with this visualization. It's on our dashboard, and this is the epidemic curve of COVID in Louisiana. It represents COVID-19 cases graphed by specimen over time by specimen collection date. And I like to talk about it a little bit because I think that Louisiana has had sort of a unique experience when it comes to COVID. Louisiana, you can kind of see here, has had 7 distinct surges of COVID cases, whereas most other jurisdictions in the US have really only had 6. Our first case was identified on March 9th of 2020. And what happened was cases absolutely skyrocketed immediately thereafter. And it was reported that Louisiana had the fastest growing outbreak anywhere in the world during the first 2 weeks after our initial case was identified. And what we know now is that COVID was present in the New Orleans area during Mardi Gras in February of 2020. And at that time, testing was very limited. And so only severely ill patients were able to be hospitalized. So what happened was there was obviously undetected transmission that occurred among people who were asymptomatic or mildly symptomatic, and they just didn't know it because they weren't eligible to be tested. And another important thing to consider with regard to that limited testing that was available at the time is that you see that first surge appears to be teeny tiny in nature, when in reality, there was a lot of transmission that was occurring. But these are cases that were detected by laboratory tests. And because we couldn't test everybody that had symptoms, the number of cases that you can see here is a dramatic underrepresentation of what was actually occurring at that time. So then, of course, we had a second surge. At that time, when we had that surge, that's when the northeastern states were also experiencing outbreaks. Now, our next surge occurred in the summer of 2020, and that was at a time when the southern states were experiencing outbreaks. These outbreaks were really started by young adults, outbreaks that occurred among college students, for example, and then it led to subsequent transmission across all age groups. Our third surge really occurred starting in November of 2020. And you can see if you look closely, this is a little bit smushed together because of the amount of time that we're representing here, that there are spikes that occurred following Thanksgiving, following Christmas, following New Year's. And of course, this is related to transmission that occurred during travel and holiday gatherings. So our fourth surge, I don't think I have a pointer, but if you count our fourth surge there, that's our Delta surge. Louisiana was one of the first states to experience an outbreak related to the Delta variant, which quickly became the dominant strain circulating at that time. And as you'll see when I get to the graph that depicts deaths related to COVID, the Delta surge was responsible really for the largest number of deaths that occurred among the surges that we've experienced in Louisiana. So this next surge, the fifth surge that appears to dwarf all of the other surges in terms of cases is of course, Omicron. That's our first Omicron surge. And of course, Omicron proved to be even more transmissible than the Delta variant. Our first case was identified toward the end of November and really sort of took over and started circulating in communities and congregate settings very, very rapidly. And then beginning in summer of 2022, we had another surge. This is another Omicron surge. This was related to BA4 and BA5, those sublineages. Now, the one thing I want you to keep in mind about this surge is what has happened between those two Omicron surges is at-home tests. So there was this dramatic increase at-home tests. These are not reportable to LDH. So if you all remembered what was happening back in the summer of 2022, everybody knew somebody who was infected, right? A lot of people got their second or third infections at that time. Well, if you look at this graph, it doesn't really show it, but that's because so many people were testing at home and those cases aren't counted or represented here. So this really is an underrepresentation of what the transmission that was actually occurring at the time. The same is true for this sort of seventh surge we're just kind of coming down from because at-home tests continue to be used at that time. I'll just say this about mortality. We've had 7 surges related to mortality as well. I'm going to get into that a little bit later, but of course the mortality surges follow corresponding surges in cases. So I've talked a little bit about the limitations with regard to case reporting. You know, almost entirely across the board, reportable diseases are underreported for a lot of reasons, and COVID-19 is no exception. So I like to present seroprevalence because I think it tells a little bit more. It's got its own limitations, but it can kind of tell a little bit more about the story. So what you see here are antibody levels that specifically indicate a history of natural infection. It's a study that CDC conducted using residual samples from commercial laboratories. The orange line represents the US. The blue line represents Louisiana. Now, these lines, this data only represent those who are under 18 because CDC for some reason stopped collecting data across all age groups early in 2022. But I've compared some of these two sets of data from earlier on, and I think that the pediatric seroprevalence data is fairly representative across all age groups. So that's why I'm including it here. So if you look and you see, look at the blue line and you see that big spike that occurs really between, looks like June and July of 2021, somewhere around there, or September and October, can't quite tell. Right there toward the end of the summer and the very beginning of the fall, that's Delta. That is Delta, and that is also when schools returned full-time, no more at-home learning, right? Even though you see this dramatic increase, the level of seroprevalence, essentially the proportion of the population that has evidence of natural infection, is only about 50%. And then that next fairly steep increase, that's the first Omicron. And after the first Omicron surge, we get up to about 90% of essentially our population that has had some sort of natural infection. estimated to have had some sort of natural infection. And then after that, we continue to increase. The most recent data show that about 95% of the population, if you estimate based on the samples that they get for these seroprevalence studies, have some sort of evidence of having had an infection. If you look at our data, we have over 1.5 million cases reported. That's not 95% of our population. So probably what's really occurring is that we actually have, instead of 1.5 to 1.6 million people that have been infected, we probably have more on the order of 4.4 of our 4.6 million have had some sort of natural infection. So really, almost every single Louisianan has been infected with COVID. So if we're thinking about what's next, and of course, immunity is important. That's why I'm focusing on infection. But vaccination is just as important. The role that vaccination plays is just as important. And what I've graphed here, or what my team has graphed here at my request, are rates of vaccination. These are total doses, the vaccination rates, total doses over time by age group. And what you can see here, obviously, I think we all know that people, the older a person is, the higher their risk for experiencing severe outcomes related to COVID. And so these are the individuals represented by that sort of lavender line at the top that have the highest vaccination rates. They're the ones who are going and getting vaccinated the most. Now, that doesn't mean that other individuals are not also at risk for severe health outcomes. They are, particularly if they have underlying health conditions. And I can tell you, just in the last 3 weeks alone, we have reported 5 cases of COVID-associated deaths among pediatric patients. All of these have been among children under 5. None of them have been vaccinated, and 3 of them have been eligible for vaccination. All told, we have 32 pediatric deaths associated with COVID, and none of those children has been fully vaccinated. So I'm going to spend a little bit of time talking about mortality. This graph shows the number of COVID-associated deaths among Louisianans over time by date of death. And as surveillance for COVID continues to evolve, I do believe that severe health outcomes are going to continue to be important to monitor because they are, I think, a more reliable indicator than, for example, case counts, because they're less able to be confounded by other things like testing practices, right? So if you look here, you can see, look at the fourth surge here. That is a Delta surge. Remember, I told you that Delta was responsible for more deaths than any other surge. And the first Omicron surge, of course, was also responsible for a lot of deaths as well. But if you look at these last 2 surges here, where we know, even though the absolute case counts appear to be low too, we know there were a lot more cases that were occurring. Even despite that, we are still seeing lower numbers of COVID-associated deaths among Louisianans than we have seen throughout the rest of the pandemic. And what I think has happened, and part of what I'm going to present is my sort of opinion about what I think is occurring. And what I think has happened is, after the first Omicron surge, we achieved a level of combined vaccine and infection-induced immunity that conferred a level of protection against severe health outcomes that our communities haven't seen before. So I don't know if you guys remember, but at the beginning of the pandemic, there was a lot of talk about herd immunity. So many questions. Everybody wanted to know, okay, what % of the population has to be either infected or vaccinated in order for us to achieve herd immunity? I don't think herd immunity precisely applies to COVID. It is attainable for a disease like measles, but what I think we've achieved for COVID, which is essentially what we have for the flu, and it's kind of what I think of as herd resistance. these viruses are going to continue to mutate, which means we're going to continue to need repeated vaccinations. We're going to continue to have infections. But what I'm hoping, but what herd resistance will mean is that infections, hospitalizations, deaths are going to continue to occur, especially among people who have underlying health conditions or of advanced age. But in the absence of, fingers crossed, a new variant, a new sort of high consequence variant emerging, our lives won't come to a grinding halt. Our hospitals won't be overwhelmed, and our residents won't die in multitudes. So I just want to very, very briefly touch on health disparities, because it's something that I think has been very positive to come out of this pandemic, this sort of renewed focus and attention to health disparities and commitment to efforts to reduce these health disparities. So I do want to quickly show, this is mortality. Again, I'm not presenting cases here for sort of reasons I've already described, but this is mortality. These are rates, right? So it's a direct comparison of Black residents and white residents, because we're looking at the number of COVID-associated deaths over time per 100,000 residents. Black residents are represented in pink and white residents are represented in green. And what you can see during the first surge, there was a very, very sharp difference. The rate of deaths among Black residents was exceptionally higher than that of white residents, and just slightly higher than white residents during the second surge. But in all the subsequent surges, the death rates among white residents have exceeded those among Black residents. And when we're talking about those disparities and this particular reversal related to COVID-associated mortality and race disparities, what you see here are vaccination rates by race. And some of the vaccination, I think it's definitely partly responsible for the reversal that you see related to mortality. What you can see here, again, white residents are represented by the purple line, Black residents are represented by the green line. And what you can see is that up until about October of 2021, white residents were vaccinated at higher rates than Black residents. Since that time, that trend has reversed, and Black residents have vaccinated at higher rates than white residents. But it's important to note that there are other factors to consider when you're looking at these data. For example, there are sort of important geographic differences that occur if you sort of, look a little bit more closely. For example, in Region 1, the Greater New Orleans area, the disparity, white residents have been vaccinated at higher rates than Black residents for the duration of the pandemic, and that has not changed. Now, in other areas, particularly rural areas of the state, such as the Lake Charles and surrounding areas and the Alexandria and surrounding areas, the difference is the same differences that you see in terms of mortality and vaccination statewide are even more pronounced in those areas. So there's definitely more data analysis, more information gathering to be done. But I did want to just present very, very briefly a little bit about what we've uncovered so far. And I hope that some of the information that I've presented is useful. As far as COVID is concerned, we have come a very, very, very long way, but we are not at the end of the road yet. And so I think that there's a lot to be discussed during this roundtable. So thank you very much.
So thank you so very much, Dr. Mendoza, too. I think it's fairly clear Louisiana has had some of the starkest racial disparities throughout the pandemic. Also has had some of the more effective responses to those disparities through the work that many folks have done, many people on this panel here. Your closing remarks, Teresa, made me reflect on, although many people are getting back to normal and we're, in carnival season, et cetera, we still are losing lives every day to COVID. In Louisiana, we average somewhere around 40 or 50 lives lost to COVID-associated fatalities a week, about 500 a day nationally, and many of those are preventable. That's the situation we find ourselves in. I also want to note the dashboard screen grabs that Dr. Mendoza pointed out. Those are all publicly available on the LDH COVID dashboard. It's ldh.la.gov /coronavirus. And it's got a wealth of information. I'll tell you, essentially all the data points that we looked at through the pandemic, that the governor looked at through the pandemic in informing his decisions and emergency orders, all of those data points are publicly available on the dashboard. It's really a world-class resource that is up there and available. Without further ado, let's move on to the rest of our very esteemed panel. To the right of Dr. Mendoza is Dr. Sunday Winder. Sunday has had over 15 years experience that includes emergency preparedness and response, community partnership building, policy development, research, and accreditation. She is the executive director of the Public Health Preparedness Program within the LDH Office of Public Health. She has served as the lead for public health emergency preparedness and response in Louisiana Region 1, the New Orleans area. That's where I got to know Sunday initially. She was responsible for assessing, planning, responding, and recovering from natural disasters, accidental or intentional releases of infectious agents, hazards, chemicals, and nuclear substances. Her work has included plan development, exercise planning, implementation, staff training, responses to multiple hurricanes, H1N1, an oil spill, Ebola, floods, and of course, COVID-19 and monkeypox. She completed her studies at Xavier, Tulane, and Southern. To Dr. Winder's right is Dr. Michelle Longo. Dr. Longo is a clinical neurologist at the Tulane Center for Neurosciences at Tulane School of Medicine. She's a native New Orleanian and a lifelong Tulanean, completing all of her studies at Tulane. She is the director of the Tulane Neurology Post-COVID-19 Care Clinic that was founded in 2020 and serves as vice chair of the outpatient neurology section for her department. She's a member of the Post-Acute Sequelae of COVID-19 Collaborative that has been developing guidance statements helping to define the standards of care for individuals experiencing long COVID. She's an active member of the American Academy of Neurology's Neuro on the Hill program, where she advocates for the necessary policy changes to help advance the clinical care of patients with neurologic diseases across the U.S. She's one of the leading experts in this state on long COVID. We're very pleased and honored to have her with us today. To her right is Dr. Sarah Al-Dahir, who's a PharmD from Xavier University, also studied at Johns Hopkins University. Dr. Al-Dahir published in Vaccine Access and Equity, Infectious Diseases, Critical Care, and International Health, specifically vaccine uptake among children in conflict areas. Dr. Al-Dahir is focused on the issue of vaccine equity and the disproportionate impact of infectious diseases on marginalized communities and individuals from disadvantaged backgrounds. Dr. Al-Dahir has done research supported by the WHO. She also conducts research and serves as a consultant for UNICEF. She has presented nationally and internationally on issues related to vaccine equity. She is currently the lead investigator on multiple NIH grants focusing on health disparities and vaccine equity. Very happy to have you with us today. To her right is Ms. Catherine Haywood, who is the executive director for the Louisiana Community Health Outreach Network. She's also the co-founder of the Louisiana Community Health Outreach Network and Women with a Vision, which is a remarkable organization based in New Orleans and has had a real track record of improving the lives of marginalized individuals. Catherine has worked for the last 30 plus years advocating for individuals living below the poverty level, also to educate communities around health disparities. She provides structure mentoring process for community members, implements training programs for community members. She partners with LSU Community Health Worker Institute to train community health workers in the state. She completed her studies at Southern University. Catherine, thank you so much for being with us today. And finally, to her right is Ms. Carla Brown, who serves as the Director of Nursing at Camden Hospice in Baton Rouge. Her personal mission is to provide exceptional patient care to people receiving hospice services and to vaccinate as many people as possible in the Baton Rouge area and beyond. As a frontline worker during the pandemic, Carla founded the COVID Crusaders group and collaborated with a local pharmacy to vaccinate over 8,000 people. Because of her dedication to underserved communities, she's been featured on multiple public programs: Good Morning America, The View, Made to Save, People Magazine, MSNBC, and Vice President Kamala Harris invited her to participate in a Lifetime Network event as well. She's also been a licensed and ordained minister for the past 25 years. She instituted several children's church programs and worked with other clergy to establish feeding programs for people experiencing homeless in the greater Baton Rouge area. She's a native of White Castle, Louisiana, and completed her studies at Southern University. Carla, thank you for being with us. Let's begin. I'm going to moderate a question and answer session here. And following that, we'll move on to questions from the audience. I'm going to start with Dr. Winder. We talked a little bit during Lee and Teresa's presentation about the overall state of the pandemic. And I think it's certainly confusing for people because there are mixed messages. Is the pandemic still occurring? Is it not? What is a pandemic? So how do you define it in your work, and where do you view us right now?
So pandemic, that is a public health term. Those in public health are very familiar with it. In order to fully understand pandemic, you need to know a few other terms. I would say endemic and epidemic to fully understand a pandemic. So endemic, we see infectious diseases that are in an area that's considered normal or usual amount of disease in a community or baseline, and that's considered endemic. When you have an increased amount of disease in a population, it's an epidemic. And then when you have an epidemic that's worldwide and there's a large number of cases, and it's typically a new infectious disease, and it's considered a pandemic. It's also important to know who declares a pandemic. And a pandemic worldwide is declared by the World Health Organization. So WHO declared COVID-19 a pandemic on March 11th of 2020. And so Teresa just mentioned our first case was March 9th. And so at that time, there were over 100 countries and continents that were experiencing cases. And those cases were increasing very quickly, very rapidly across borders, international borders. And so that's how we came to a pandemic. And that's how we define pandemic.
Thanks, Dr. Winder. Let's talk a little bit more on a patient level. Dr. Longo, one of the challenging aspects of COVID is that its symptoms resemble so many other things. And not even talking about long COVID, we're talking about acute COVID right now. How do you advise patients who aren't sure if they have COVID or what they should look out for, particularly in the context, we're coming down from a flu season, we're coming down from RSV, it's beginning to be allergy season in Louisiana. What's your advice to patients if they don't know what symptoms to look out for or how to ascertain what they have?
So, so I'm a neurologist, and so typically when I'm having this conversation with patients, it's when they are trying to determine if a previous illness could have been COVID when they're seeing me for the question of long COVID. So I tend not to be that person. So Sarah's going to take part of that, but I can tell you what my strategy is that, for sinus infections, typically there are symptoms like pressure in your face, or your teeth hurt, or there's pain in the cheeks, and a discolored nasal discharge and a postnasal drip. So I'm listening for things like that for sinus infection. Now for cold, I mean, most of us, I think, know cold symptoms. You got runny nose, you might have headaches, you might have be sneezing, but when those symptoms tend to be milder than what we were seeing initially with COVID, although with the Omicron variants, the symptoms could be a lot milder than what we saw with the Wuhan and the Alpha Delta variants. But so differentiating like flu from COVID-19, I don't think you can do that clinically. You need a test. When you've got muscle pains and you're fatigued and you got a cough and a runny nose, that could be either. The GI disturbances, you're having some nausea or diarrhea, We don't typically see that with a cold, that makes me a little more concerned about the possibility of COVID. And initially, the loss of taste and smell we were seeing with COVID, you can see that with sinus infections, but I don't think it was as commonly seen as what we were seeing with the initial COVID. So I got to tell you that's a tricky thing to do, and a good resource are our pharmacists. So I'm going to let Sarah talk about her strategy for that.
So yeah, we actually discussed this a little bit before. So the most important thing is if you're a patient who has asthma, diabetes, hypertension, and you're going to the pharmacy and you're looking in the cold and flu aisle, go ahead and go to your doctor first before going through the cold and flu aisle to try to self-treat it. That's the most important thing. A lot of those medications can make some of your underlying diseases worse. And the second most important thing is the testing, as Dr. Longo said, to really differentiate in terms of how the treatment options are available for you.
Great, thank you. Dr. Alder here, let's talk a little bit more about treatment. So not vaccines, not preventative measures, but treatment. What's available for you if you unfortunately do get COVID? Now, the pandemic has only been with us for about 3 years, but we've already gone through a number of medicines to treat. Some are still working and available, some are not. What's the availability now, and how do people best access it should they need it?
So that's a great question. So the FDA actually still has 2 of the medications under emergency use authorization, and 2 of the medications are actually, you can actually have it provided to you by your pharmacist. So there's Paxlovid, which is actually not a new drug. It's a combination of some very old antivirals that are available. So a lot of concerns about how well has this been studied are largely mitigated. The key is you have to present and ask for it within 5 days of presenting symptoms. And it's only for individuals who have mild to moderate COVID. It can be used for children as young as 12 years of age. An individual has to weigh at least 88, 90 pounds. So it's not for very small people, whether adults or children less than 12. We have another drug, which is only recommended if they're not, as if Paxlovid would not be indicated in this person, and that's Lagevrio. It's made by another pharmaceutical company, and it's still the same rule about you have to catch the symptoms within the first 5 days, mild to moderate COVID. And finally, if a person does end up requiring hospitalization, we still have that first drug that came out in the beginning of the pandemic, which is IV remdesivir, which we're giving in the hospital for much more severe and critically ill patients. So all of these drugs have been found to reduce morbidity and mortality. Particularly the oral ones have reduced hospitalization rates and actually have anywhere between only a 2 to 9% recurrence of COVID after taking the drug. So they seem to be working. I do want to say though, because you mentioned vaccines, particularly some of them have the efficacy is heightened by giving if among those who've received a vaccine. So I have to say that.
No, thank you for that. And it's not normal, I think, for most people to go to a pharmacy to get a medicine without having it been prescribed by their doctor or NP. But for the oral treatments, Paxlovid and Molnupiravir, there's now allowances for that to happen. Can you talk a little bit more about how that works and if or why that's a good idea here?
So I think if someone's at a high risk for developing a severe infection, they absolutely have to go to their physician. So I really want to do that. I think we also have to couple it with testing. So not, I can't tell if it's a cold or a sinus infection. The benefit of the pharmacy is and your physicians, they have the full list of medications so they can review for medication interactions. But if somebody is at any high risk category, has underlying conditions, they should, of course, first go to see their physician. If that's not an option, let's say it's Friday before Mardi Gras, which is next Friday, and you're starting to feel COVID-y and you're afraid you're not gonna be able to get to your physician till Thursday or Friday. That's not an adjective, COVID-y. It might be, and you are not at high risk, then you can go to the pharmacy and they can run it through your insurance for you.
Yeah. And you did mention that time is of the essence with these medicines. Great, thank you so much. Ms. Hayward, let's talk a little bit about community health workers. So, this pandemic exposed a lot of gaps, pre-existing gaps in our healthcare system. In that though is some opportunity. Community health workers are an area you've certainly worked in well before the pandemic, but new opportunities to engage CHWs emerged through the pandemic. How do you view those? How have they been used? What lessons do you draw from that?
Well, you're asking a whole lot.
A whole lot.
For the pandemic, there were hundreds.
Could
of
you,
new-
a little closer to the microphone?
Can you hear me? Hello? There you go. There were hundreds of community health workers who were hired, new people, hired, trained to work because of COVID. And so these people who are still around, go to homes, they're frontline workers. They were out there in the beginning. When all this started, they didn't stay home. You know, they weren't in a clinic, they weren't hiding, and they're linked between that, the community people and the physicians. And it's important for them to be out there. They're still there. They bring food. They do, you know, home visits. They educate. They try to get people to get vaccinated. Because even for me, it was like, I'm not doing this. I don't trust this. It's not happening, right? That's what we say. As Black people, we just don't trust. So they were there to educate and tell them the importance of getting this. And the other side of that, some of the family members might have been dying, so the people were able to see. And so the CHWs who were working for COVID, around COVID, were able to help them find transportation if it was necessary to a site that was doing vaccines, right? Dr. Cannon, you had a whole lot of questions in that one question.
Well, no, I think you covered most of them.
But anyway, they're the link between hospitals and getting people vaccinated before they get to the hospital. So that's not a necessary thing, which was a great thing, even though we had a whole lot of people still being infected, still getting COVID, still going to the hospital. But we also had a whole lot who it didn't happen just because we're out there. We're out there talking to people. We're out there educating people. And for the ones who did get COVID and stayed home, community health workers were bringing food. They were going helping them to get their medication. They were doing a whole lot of things that they couldn't do. And that's what we do. That's who we are. So
You mentioned trust. I wanted to dig a little deeper on that. You know, myths and misinformation has become a big challenge throughout this pandemic. And I'm thinking to the early days of the vaccine campaign. There was this myth that unfortunately got spread pretty widely in the Black community in Louisiana that the vaccine would cause infertility amongst women of reproductive age. Now that's since been disproven resoundingly by a number of studies, but it was tough to combat during those early days. How do community health workers approach something like that?
Again, I'm gonna say they're the trusted members of what community. And for a lot of people in communities, if I go into a community that I have been working with and talking to people and go in with some kind of proof that says what you're hearing is not true. This is this is that, right? This is what's going to happen. Then for the most part, they're not going to believe it. But somebody has to go into that community and actually sit down and talk with people. Yeah, we go to clinic, we run in, visits 15 to 20 minutes because physicians are extremely busy and have more patients. But having somebody out there who's not in the clinic, who looks like you, that works. That helps them. My thing was not because I'm old, but the thing was Tuskegee. I do not, and I am not, and I do not trust community health worker here. Have to have other conversations, right? In order for me to do what I needed to do. So.
Great, thanks.
Right.
Talk a little bit more about community work. Ms. Brown, Nurse Carla, you set a personal goal of vaccinating 2,000 people during this pandemic, and you well exceeded that. You've been on the ground, you've helped reduce barriers for people to get vaccinated and a host of other things. What have you learned personally, and what do you take away personally from the experience?
Well, it was 4 things I learned on the groundwork. As you all just stated, trust was the very variable we had to deal with. as we went door to door, it was so important for communities to see people they can trust out there administering the vaccine, conveying to them the vaccine is safe, educating that the vaccine was not made to cure us, but it was to prevent us from having to go into a hospital and have ICU treatment than just going in to have we call maintenance therapy. So the trust was one of the biggest valuable. The community needed to know that you cared. You know, you were there to listen to them. And besides listening, you took action. So some of the lessons I learned that was very hard to overcome, that religious leaders and politicians use this as a propaganda. So we had to deal with a lot of valuables as we went from door to door, educated and teaching the importance of, taking the vaccine. It's safe. We also did what we call extended love. As a hospice company, we made sure every one of our residents received the vaccine because family members still needed to see and take care of them. So it was about celebrating life, but also overcoming those variables,
Yeah.
Dr. Cantor.
Now, it makes me think about the power of personal connection, both as what Catherine said too. I mean, the data can be as robust as possible, but sometimes you need to really reach people face to face to make a difference. Thank you for the work that you did. Let's broaden a little bit and talk about where we are now and what's coming next and moving, from the acute phase of this pandemic onward and post-COVID and everything else. So move back to Dr. Winder. Dr. Winder, in your work in emergency preparedness, I know your day-to-day is very different if we're in the middle of an emergency response versus a normal sunny day, the hours you sleep and so forth. With regards to COVID and the pandemic, where are we now? How do you mark that?
So now I know it feels a lot different, right? So if we look at where we were in March of 2020, it feels a lot different. The things that we in the community when we go out, and we're going out now, right? So it feels different. But know that we still have individuals that are at risk of severe illness and death. And so now we have vaccination. So that's number one for prevention. We need vaccines. We need layered approaches, right? We need for those that are protecting themselves or protecting other family members they need to go home to, we need to make sure we have other layered protections, PPE, masking, et cetera. We have treatments now. So we talked about Paxlovid, we have treatment. So that's great. We also have, I know in the beginning, we were like, when will we get to herd immunity? So we have prior immunity. And so we're in a much better place, but we still have the threat. We still have individuals that are vulnerable. You and I may not be as vulnerable as an elderly loved one or a loved one that's a newborn. But those individuals, some individuals are still not eligible, very, very young, not eligible for a vaccine. And so there's still a threat, and we still do have a pandemic. It hasn't been declared to end yet, but we do know it feels different, but know that that feeling is a personal feeling, and there are still individuals that are at risk.
Thanks. Let's talk more specifically with Dr. Longo about long COVID. So as Teresa showed in the data, the overwhelming majority of Louisianans have had COVID, overwhelming majority in the country too. That's potentially a lot of people that are at risk of long COVID. And I know we're still understanding what that is and what causes it, but in your clinical view, how do you define long COVID? How do you recognize it in patients, and how do you engage with those patients? What do you offer them?
So I was thinking the same thing when I heard 95% of us have had COVID. Wow. So the pandemic was announced in March of 2020, and we waited until October of 2020 before we had a definition, before we had a case or a clinical definition of long COVID. So up until that point, people that had COVID, that were struggling with symptoms, were getting together on social media sites and saying, my family's better, people at work are better, but I'm still struggling here. Is there anybody else out there? And they formed these social networks that came up with the term long COVID that we're still using. And they really kind of defined for us in patient-led research what long COVID looked like. And those patient-led research, when I look at the study that was published in Lancet, and I compare it to what we're doing today, boy, the patient-led research was right on the symptoms and the way they described this. So the World Health Organization gave us a definition October 2020, and I like this definition for several reasons. All right, first of all, it said that you had symptoms that were lingering for 3 months. Now that's kind of a long time, right? Because we know if we get the flu or something like that, if you've got symptoms, 4 to 6 weeks, you're like, something else is going on here. So there are some definitions for long COVID that say, okay, 4 or 6 weeks, like the CDC definition. But the World Health Organization took the longer side here. And they said, all right, 3 months, it's been 2 months since since the infection. You have symptoms that most commonly are brain fog, fatigue, and shortness of breath. Although there are other symptoms, there's over 200 that have been described, but these are the most common. And these are two important factors in that definition. The symptoms interfere with your day-to-day functioning. That's real important. That's in the case definition for long COVID. It's interfering with your ability to go to work, to go to school, to do your chores. It's interfering with your functioning. And the other part that they put in there is that the symptoms can fluctuate. That's real important because some days people with long COVID feel really bad. And other days that they're starting to feel a little bit more, a little closer to their baseline. And this fluctuation, as you know, that makes people not believe people when they're talking about their symptoms. So it's in the case definition that those symptoms will fluctuate. And then here's the catch-all. It is a diagnosis of exclusion. So you got to think about all those other medical conditions that can cause these symptoms that can be seen with lots of other conditions when you're talking to a patient. So there is not a test. This isn't like pregnancy. We cannot say you are pregnant from this test. We can't do that with long COVID. We don't have it yet. So it is what we call a diagnosis of exclusion. You got to hear the story, know the patient, maybe follow them for a while, really understand what were their underlying health conditions before you could even start to think about long COVID. Mm-hmm. And so my approach is to, number one, listen. Number two, beg for time with my patients, because I can't do this in 10 or 15 minutes. It takes time to listen. And then really constantly thinking about, as I see that patient and we talk, what else could this be? If they're not on the trajectory that I see a lot of patients on, which, we just have studies that have said over the course of a year, people get better. If they're not following that trajectory, then I constantly think, well, what else could this be? Say one other thing.
Absolutely.
I want you to know, as a neurologist, this isn't new for me. One of the most common conditions that I treat as a general neurologist are migraine headaches. There's not a test for a migraine headache. And I got to think about other things that are causing that before I call this a migraine. And every time I see a patient with headaches, I wonder, did I get that diagnosis right? Are they responding? Are they doing, is this going the way I think it should be going based on what we understand about migraine? So I don't want you to think, well, she just said long COVID could be anything and everything. That's how a lot of things in medicine are. And so for me, that's not such an unusual position to be in.
I imagine, Dr. Longo, you see a lot of patients that are frustrated. They have debilitating symptoms. They have symptoms that other people can't see. So maybe they doubt them or stigmatize them. And they want answers. Why are they feeling this way? How often are you able to get answers, and what happens if you can't give an answer?
You know, so many of my patients are just, they're so appreciative. And I have to tell you, this is what fuels my soul and keeps me in this work that I think is pretty tough, is that they are appreciative to have somebody listen and believe them. I have a slide on my migraine talk, and the Dean Ham told me, don't take it out. It says, believe your patient. I use the same slide when I'm talking about long COVID. So having somebody to listen and be thinking about the symptoms and be considering what you're saying, I think is really is important. And then having a clinician, I've been working on this, who's humble enough to say, I don't know, but I'm going to stay with you on the journey. And I'm going to learn with you, and I'm going to bring around, other people on the team that can help us out here. But that's kind of a humbling part of taking care of patients with long COVID. Initially, medical gaslighting, I learned that term through my care of patients with long COVID. Initially, I was hearing a lot. The first 10, 15 minutes of the visit were undoing what I feel other people had sort of done. And patients were coming and saying, I've been in the emergency room. They told me I'm anxious, or, people, my doctor says I just, that it's just everybody's is tired from the pandemic. Medical gaslight was more of a problem I found a year and a half ago than what I've been seeing more recently. And I truly believe it's because of things like this. And because we have had the opportunity to be talking to primary care, to be talking to health leaders about long COVID. I don't see it as much as I did before, although I know we still have a long ways to go. I am seeing some improvement in terms of people out there, clinicians saying, maybe I know a little bit more about this today, and I better not tell this patient that, that these symptoms are just due to anxiety or the other things that we often get told when we are we know female or from or if we are or minorities, or if we have other health conditions that people will quickly take every other symptoms that we present with and say, oh, that's your this, that's due to this. So I better stop there.
We'll come back to you. Thank you for that. Let's talk more about treatment. Dr. Aldark here. Any treatments for long COVID?
Actually, what I'm going to do, I'm going to have Dr. Longo jump in on this as well. But I think what's the important thing that she said is that in October of 2020, it was diagnosed, and I'm not, the terminology was offered to everybody, and you're having a 3-month condition. And the prevailing treatment seems primarily to be time and early identification, which is now at 6 weeks, and then early rehabilitation. The Nature study, which came out, which did a very large review of literature, and they did find that even post-COVID, having COVID, but then receiving vaccination afterwards is associated with less long COVID. And there's a lot of old drugs that they're actually recycling to see if they work. And Dr. Longo actually leads some wonderful trials, the recovery trial. So I'm going to let her speak to what medications that they are putting through there outside of just rehabilitation efforts.
So right now we do, you heard me say we don't have a test for COVID. Here comes the second part of that. We don't have a treatment. There's not a medicine that I could grab and that's going to treat all your long COVID symptoms. We don't have that. We're just beginning to start getting trials to be looking at treatments. What we needed to first do was understand something about what's causing this so that we could get some idea of what treatments to even try. So we are going to be you're going to be hearing more and more about some clinical trials that are going to be done. We will be starting one at Tulane within the next hopefully couple of weeks. So we treat the symptoms. That's true for a lot of things in medicine, right? We treat the symptoms. And so we've learned a lot from patients. There are interventions that help. We know that we can't tell our patients that, oh, you're having a good day, go run out and get everything done before you feel bad again. They have to pace. They have to use energy conservation strategies. That's helped a lot of patients. A lot of patients have coped better with some of the brain fog with cognitive therapies and some strategies for that. And then, we've been when we do find mood disorders, we treat those, or sleep disorders. We will treat that. You'll hear about a lot of different treatments that people are trying. And what I tell my patients is, let's do things within the context of clinical trials. And if I'm not offering them here, you can go to clinicaltrials.gov and see if there's a trial that you're interested in. But I really try to encourage my patients to be involved with the clinical trials so that that this is being monitored. But those are some of the strategies that we have. We are developing guidelines for best practice for treatment of this, and I'll wait till the end, I guess, for that.
Okay, great. Move on to Carla. Let's talk about fatigue and motivation. It's been 3 years of living in a pandemic, and we're all tired. I think that's fair to say, and that complicates things, and it makes us think unclearly. But as Teresa pointed out in the data, we're still losing lives every day, and there are things that we can do to prevent that. And I'll just mention the CDC came out with revised data yesterday on the effectiveness of the vaccines and boosters, and people that are up to date, meaning they've had the most recent updated bivalent booster, they're 3 times less likely to die than people who just had the initial vaccine series but no booster, 14 times less likely to die than people that are totally unvaccinated. And so you add those up, those are real numbers across the population. So how do you motivate people? How do you encourage people to protect themselves and protect their families, even though, quite frankly, they're fatigued and exhausted with COVID right now?
Well, one of the things we do, first of all, because of the fatigue, it has affected millions of people physically and emotionally and mentally. We ask them to seek counseling, to get help in the community. But even though that fatigue is there, we still have to stay on target with the same message we did at the height of the pandemic. That is, it is a race against time. So the message cannot change. I know we are tired of COVID. I get it, but the message cannot change. People are still testing positive for COVID as of today.
Mm-hmm.
People are still dying. So the message, vaccination, is your first, most important thing you can give or offer your loved ones right now. So besides seeking the counseling, we still tell them you have that choice. The vaccine will prevent you from having a hospitalization stay where you may end up in ICU, alternatively dying, whereas that vaccination can help prevent that.
That's great messaging. Catherine, let's talk about community health workers in that space, going forward, as we, kind of emerge more from the full-blown pandemic into more, I guess, normal operations in the health department and in our health sphere. What's the opportunity for community health workers? Where do you want to see them play and help out?
Actually, before COVID, they were already in the community doing other health education, helping to get people into the clinic, advocating for people to get the services that they need. They work in or around diabetes or hypertension or whatever that people need, housing. So actually, we've been talking about how do you get back to what you were doing before.
Mm-hmm.
Not forgetting about COVID, because they're not going to forget that. But people have everyday lives. They're not just sitting home because they're confined. They have to go to work, they have to do this, but they're ill. or to prevent them from becoming ill, we need to be there to just say, okay, you have this. This is what your doctor said. So now you need to do this. We help with healthy eating. We have to get back to all of those things. The other side of all of that is that people have to work. They have to. So you're telling me I have to stay, I have to do this, and COVID is not as bad as it was. What's important to communities that I have to feed my children, I have to pay the rent, I have to do this. So we're back to where we were before COVID, talking about all these things, educating about all these things, and helping people to get where they need to be in order for them to stay healthy, move forward, and those sort of things.
A lot of people deferred things during the pandemic, self-care, routine cancer screening, anything like
Right.
that. How do you approach those conversations? How do you get people to kind of regain the self-care that they need
You
to?
don't want to ask me that to be myself and tell you exactly what I say, because I'm not gonna tell you that. But
We can bleep it out if we need to.
But you just have to sit and encourage them. We understand. I'm going to listen to you tell me about, well, this, and this, but then when you tell me, well, I can't go do this because of this, then I'm going to sit and tell you, you have to find the time. I might even tell you, you know what? Remember you told me your sister had this and your sister died because your sister didn't go do what she needed to do. I'm being myself,
Yeah.
right? You have to do these things to take care of you. You have a family, you have a whatever. And so sometimes you get through like that. Other times you might have to take their hands and walk them to whatever. They're afraid or they don't want to talk to a physician, and you have to help them. So that's what, I really don't want to be myself and tell you all of what I might say, but
We're getting short on time. We could have this panel for 2 more hours, I think, and not get bored of it. I have one more question. I want to talk to Dr. Alder here about, and then after that, we'll move into questions from the audience. So looking forward to what's going to come down the pipeline in the next couple months. The Biden administration has indicated that on May 11th, I believe, the federal public health emergency is going to expire. Our state public health emergency expired 11 months ago. Those who have enrolled in Medicaid through the pandemic or were not allowed to be disenrolled because of the federal emergency, that protection goes away in the beginning of April. And so we expect there'll be a large number of people, unfortunately, in the state and nationwide who will lose Medicaid coverage or have to be transitioned. With that comes access to therapeutics. So what do you see coming down, and how can people access medicines for COVID through that?
Yeah. And that's a really excellent and kind of scary question, because we don't want COVID to fall into those disease states that may have been better managed early. Like when we think about the emergence of the HIV epidemic early, and regards to early access identification and motivation to seek treatment and testing. So Xavier University, of course, as many of y'all might know, is an institution that's dedicated to health disparities. And so they have been doing a lot to increase at least the patient's understanding and the community's understanding, particularly with wonderful community healthcare workers and partnerships with Tulane and LSU, to at least have the patients begin to work a bit as their own advocates in being able to self-identify. These are, we need access. And I think there's going to be a lot of cost shifting to already free run clinics or FQHCs that seek alternate forms of funding. And have we really looked at it in terms of how is this going to play on the kind of health economics platform in terms of cost shifting, and is it an ethical cost shifting? And I think most of us who are healthcare providers would probably agree it's not an ethical cost shifting to put it more on kind of nonprofit agencies or on the impetus of the patient in terms of figuring out how to get treated and tested for something that we know not only causes immediate morbidity and possibly mortality, but also long-term symptoms. So we see that. So pharmacists and of course community health workers, they're easy, they're accessible, and they are already looking for ways for continuity of care for their patients. But
Great.
there does need to be reimbursement for it, and there has to be a way for patients to be covered for it.
Yeah, a lot of
Yeah.
gaps are still there.
Yeah.
Well, let me take one personal privilege before we move to questions and plug a couple items I think are important for people to hear. At the moment, for the next couple months, vaccines and boosters remain 100% free for every person in this country. If you have not gotten the updated bivalent booster, and you got your last vaccine dose more than 2 or 3 months ago, you are eligible for that. And if you've already been vaccinated, getting the updated booster from the CDC's data yesterday reduces your chance of dying from COVID 3-fold, 14-fold if you haven't been vaccinated at all. So real benefit for people and still free for everyone in the next couple of months before it rolls to people's insurance and commercialization. So the best single resource to find a free updated booster near you is vaccines.gov. It'll pull up a mapping feature and it'll show you the pharmacies and other clinics in your neck of the woods that has the vaccine. Again, still 100% free for everyone in the country for the next couple months. So take advantage of that. And the last item I do want to mention in relation to what Dr. Alder here was saying. So starting April 1st, the federal government is requiring state Medicaid agencies to begin reevaluating Medicaid enrollees and conducting redeterminations, which has not been happening during the pandemic because it was an emergency. 42% of Louisiana is covered by Medicaid. It's a lot of people who are going to go through redeterminations, and there's going to be a number of people who lose Medicaid coverage through that. The best way people can protect their Medicaid coverage and not lose it is to ensure that their Medicaid provider has their updated contact information, updated address, phone number, and so forth. So if you receive Medicaid or your family does, be on the lookout for information coming in the mail to help you keep your contact information up to date. And you can be proactive and call your Medicaid provider, make sure they have your best contact information. That's the first step in this redetermination process. That'll help prevent unnecessary disenrollments. With that, let's transition and take some questions from the audience. So I'm going to repeat the question so that we can hear it on the microphone. The question is, what is herd immunity? I'm going to add to that, is it applicable here? Teresa got into a little bit of that in her presentation. I'm going to ask her to pick it back up. We're now 3 years into this. We talked a lot about herd immunity initially. Doesn't seem to have panned out the way some people hoped. What is it, and is it really applicable?
So herd immunity refers to a time when a high enough proportion of a population has achieved immunity to a particular disease, either through vaccination or natural infection. And the reason that I said it doesn't precisely apply to a disease like COVID is that immunity really implies imperviousness or insusceptibility. And that happens with measles. If someone gets measles, if they're naturally infected with measles, they're not going to get it again. They're protected for the rest of their lives. If someone is vaccinated against measles, it is one of these vaccines that protects people from developing the disease again. It's excellent at doing that. So herd immunity can be achieved when a high enough proportion of the population is infected or vaccinated for measles, right? But COVID, what we have learned over these years, and it's the same for flu, right? It's why we get the flu vaccine every year and why people have had flu multiple times. These are viruses that mutate frequently. And so when that happens, it makes us susceptible to repeated infections. And that's why we need new vaccinations every year for flu. And it's probably going to be something similar for COVID because the formulation of that vaccine needs to change in order to match the strain that is going to be circulating that year. And so that's why I kind of think of it more in terms of herd resistance. We have all, when COVID first hit, there were no vaccines available and nobody's body had previously been exposed to this pathogen. And so we were all completely 100% susceptible to illness. That's not the case anymore. As I said, I estimate about 95, based on CDC data, 95% of our population has been infected with COVID. And what, 53% of the population in Louisiana has completed their primary series. I think closer to 60% has gotten at least one vaccine. So over time, we have achieved a high level of some level of immunity. And what that immunity essentially provides is what we've talked a lot about here: protection against severe infection, against severe illness, hospitalization, and death. That is not true across the board, because there are some people whose immune systems just don't mount an a robust response, either related to the vaccine or to an infection, right? This is a minority of the population, but it's important to keep in mind. So this is one of the reasons we're going to continue to see infections. We're going to continue to see hospitalizations, and we're going to continue to unfortunately see deaths. But what we can do is continue to encourage people to get vaccinated and to continue to take those measures to provide education and inform people of their risks, and especially let people who are at the highest risk still understand how they can protect themselves.
Thanks, Teresa. We'll take a few more questions. I do acknowledge that we're at 11:30 at time. So if you do have to leave, we thank you for joining us. But because there's a lot of good questions out there, we'll stay a little bit later and take some more questions. Yeah.
There's a question about, are there any long COVID clinics in New Orleans yet?
Great question. Dr. Longo.
At one time, we had 3 adults clinics. We've always had the Children's Hospital long COVID clinic. So we have one of the few pediatric long COVID clinics at Children's Hospital. There's only about 12 of these in the country. We have the neurology post-COVID care clinic at Tulane, which is a specialty clinic. We're primarily seeing patients that have neurologic symptoms. But as of right now, we do not have a primary care approach to long COVID care in our state. Many of the, but I can tell you this: you can go on Survivor Core, and this is a patient support group that has a map of all of the clinics throughout the country, and many of these clinics have will accept telehealth and accept patients from all over the state. Northwestern, it prides itself that I believe that they've had somebody from every state in the union at their clinic. So I do let my patients know that when they're asking, but moving forward, the care of people with long COVID is going to be more and more in the hands of the primary care clinicians. And that's where, if I could say this, that's what our message is that if you have concerns of long COVID, you should see the clinician that knows you best, which for most of us is a primary care clinician. But in saying that, we're starting to see that there are many people out there that don't have care established with a primary care physician. And so that's a real important message for us to do as we go out and talk about long COVID care clinics, is making sure that people know where can they get primary care from, what are their options.
We were chatting a little bit before the session about the need to integrate long COVID care into the primary care. What would you like to see happen to help speed that integration?
Well, thank you for that opportunity. So I think, first and foremost is making sure, when we had a talk with barbers in New Orleans, asking them about long COVID and what they were hearing, they told us, and I said, to recommend that their clients go to the physician that knows them best, or the clinician that knows them best, to the primary care person. They put their hands up in the air and they said, they tell us they don't have a primary care provider, or if they can get one, it's going to take months. Yeah. So I think that expanding that network of primary care is important, and then doing the part of getting information out about what we've learned. What are the resources for long COVID? We're writing guidelines, but we're struggling over how to get this out into the community It's being published in the journals and people that do this are talking about it, but trying to have more outreach so that primary care doctors can and clinicians can learn about long COVID. And a little plug, we are having a post-COVID condition symposium at Tulane on April 21st. And this is being sponsored by Lucille. Thank you. Because this is the opportunity we've been looking for, to be able to go out and say to people that if you want to learn more about long COVID, come. This is going to be primarily targeted to primary care.
Oh, great.
We have this event, which I think will help.
Maybe a couple more questions?
We received several questions about face coverings. What is the current guidance regarding wearing masks in public? Is it still recommended?
Teresa, you want to take that?
So at this point, wearing face coverings in public really is a personal choice. And it's based on a couple of different, you can make the choice for different reasons. It can be to protect your own health. So if you have a health condition that makes you more vulnerable to high risk and to a severe illness, if you get infected, it's a good idea to wear a face mask. If you have someone at home that is vulnerable to severe health outcomes from COVID, it's a good idea to wear a face mask to prevent yourself from getting infected. That being said, there are other tools you can use as well. If you're concerned about yourself, but you may not be that vulnerable, but I'll give you an example personally. I am as vaccinated as I possibly can be. I'm healthy. I don't have a condition that's going to put me at high risk. One of my concerns is about transmitting the disease to other people, right? That I don't know that might have vulnerable population. I just went to a meeting. So what I did was, people were not masking because there was a lot of conversation, sort of like here. I tested myself with one of the at-home test kits every morning before I went to the meeting. That's another thing that you can do to help protect other people, particularly if you don't know what their status is and you know you're going to be in close contact. If I go to a grocery store, I flew on an airplane to go to the meeting. You better know that I wore a mask on that airplane, because that is to me, a high risk for transmission, because there's not good ventilation and because you have a lot of people in close proximity. So it depends on the situation. It depends on your own personal tolerance for risk, your own personal health status, the health status of those around you, and other measures that might be available that you might want to take as well, because there are a lot of options that are available. I think Dr. Winder, talked about a layered approach. We can incorporate that into our daily lives as well. And masking is an important component of that.
I'll note that one of the things that has changed through the course of this pandemic is the availability of these masks. In the early months when we were doing the first couple of surges, I mean, there weren't enough masks for doctors and nurses in the hospital. We were having to reuse them and sterilize them in these crazy ways. It really was remarkable. Now they're very easy to get. And I still practice as an ER doc, and I'll tell you, when I go in to see a patient with a known highly contagious respiratory virus or disease, or a patient with tuberculosis, for example, or a known COVID patient, I'm wearing an N95 or a KN95. The same mask that you can now get online, you can get like a 30 pack of KN95s for like $10 or so. So very accessible. And so one of the big changes of the pandemic is, in the early days, the only way to protect yourself was if everyone else around you was masking. That was it. Now you can wear an N95 or KN95 and have essentially the same level of protection that a doctor or nurse has in the hospital when they treat a patient who has a known respiratory virus.
I'll also say that's what I wore on the airplane. But you can also tailor your masking practices according to community transmission that's occurring. So if there are low levels that are occurring, you might feel more comfortable going without a mask. What I do for my children, if I see community transmission starting to increase, they wear masks to school until I feel comfortable that transmission is starting to decrease and that there are low enough levels. So pay attention to the dashboard, and that can also help inform your decision about whether or not masking is right for you.
Great. And take one more question before we wrap it up.
The final question, we received several questions regarding resources. Where can people go to access the most current information and resources regarding COVID?
CDC. CDC.
That's a broad question. So, because there's a lot in there, maybe we'll just go to each panelist and ask, what is your favorite resource that your go-to place for information about COVID right now? I'll start with mine. Mine is vaccines.gov, because the most important thing for me right now is that people that want to get vaccinated or boosted know where to do that. And again, free for the next couple months. So vaccines.gov is my favorite resource.
I personally like the LDH dashboard. There's no bias there at all.
Yeah, I don't know what to say. Yeah, ldh.la.gov/coronavirus.
So I know what the end of the table will say, so I will also say ldh.gov, but for the public, if you may not have access to the internet, if you need to call, 211 can provide you with the information you need, where vaccination sites are, testing sites, et cetera. So an easy number to remember for the public, 211. And they utilize ldh.gov and CDC.
Excuse me, but I'm gonna tell you CDC. I'm also gonna tell you the National Association for Community Health Workers. I'm gonna tell you about her stuff. I'm gonna tell you about all these places, because again, everybody is not connected to where they can go on the website and look at this, because they can't. And so for us, we take all of that information that we can pull and do and make sure that it's out. It's a face-to-face. Let me bring you this. Let me walk down the street. Let me give you this kind of thing. So, yeah. All right, it's time for me to roll out.
The CDC has a section for clinicians and a section for the general public on long COVID, and it's excellent. And so I often print out the resources from there for my patients.
And well, my answer is E, all of the above. In addition to that, it's a shame the question wasn't where do you not go? Because that would have been a whole list of where not to go for information.
Okay. And Carla?
I would like to just ditto off of Dr. Summers, but add one more thing, that those of us that can go into these different websites, I would challenge everybody in this room. If you will make copies of that information, place it at your children's school or local pharmacy for people who cannot access the website, they can have that data in their hand. That's it.
Great. Listen, there were many more questions that we didn't get a chance to talk about in person. We'll do our best to answer those on the back end and send those answers out. I want to thank everyone who was here in person and virtually. Please join me in giving a giant thanks to our very esteemed panel for joining us. Really appreciate it. A lot of very busy people on this panel who took a lot of time out to come today. So thank you sincerely. That'll pass it back over to Devondra.
Yes, thank you so much, Dr. Cantor, and thank you to all of our panelists today. We truly appreciate it. Thank you for the audience, both virtually and in the room. You all have asked wonderful questions. I hope you walk away with a wealth of information and knowledge. I will add that I will say all of the above, but then also cross-check all of those. Make sure that they are the same information across the board. You have all of these panelists here, public servants that you can always check in with and make sure that you can commiserate that same public information with them, because these are trusted officials, right? So you come back and say, hey, is this right? This is what I see. .govs, .edus are your best accurate information. .coms are a little questionable, and .org sometimes people are getting tricky, and even the ones that are questionable are making .orgs. So .govs and .edus are your real trusted online sources. And as Dr. Winder said, 211 for confirmation. With that, please make sure that you fill out your surveys. If you are in the room, it should have been handed to you. It is your exit ticket out of the door. Make sure that you also get your blue card if you parked in Galvez. And for those that are virtual, the link is in the chat. Thank you so much and have a great rest of your day.